Commander Dr. Amit Sethi for Surgical Captain, Management of Lens and Angle Injuries and Trauma specific to Navy. Few takeaway points whenever you have a ocular trauma, specifically corneal trauma, including lens trauma. See, please remember it is the integrity of the globe which is of paramount importance. So first thing you should do is to make the globe secure. Lens is always secondary, so never try and not to go for a cataract surgery in the same setting. There are few scenarios where you can go for cataract surgery in the same scenarios. It is only when the lens matter is fluffy, you have lens matter touching the endothelium, or you have a situation where glaucoma is there, or that is because of intumescent lens. Otherwise, avoid doing a cataract surgery in the single stage. Just secure the cornea. That is the first thing we should do.
Good afternoon, my fellow speakers. They've spoken on management, ocular management, trauma management in the Army and the Air Force. Now I'll tell you about trauma, which is specific to the Indian Navy because of the various ergonomics as to in the ships and the submarines and the way people work there. Ocular trauma has been an unavoidable hazard of industrialization with the advent of machines in today's world. The highly mechanized war machines, including the ships and the submarines, always pose as a threat for ocular accidents in different forms. Now, in the ships, there is restricted space, as you can see in this in the pictures. Now, these are the bunks where the sailors they stay, and one can see that there's hardly any space to move around. This space is much more restricted in the submarines, and as you can see that these sailors, they work and they do all their activities between the torpedo tubes. Now, moving in a ship from one deck to another deck is through these narrow ladders. Now, the incidence of slipping, tripping, falling, and the incidence of ocular trauma and orbital injury is much more common working in these conditions. Then we have frequent fire exercises, that is gunfire exercises, missile firings. So the incidence of fire injury is very common. Now, certain activities like the aircraft carrier. In the aircraft carrier on the flight deck, the aircraft, they are landing and taking off at a very high velocity. So sailors or all those working at the flight deck, now there are some foreign objects which would be lying there. There's an increased incidence of these foreign objects hitting the eye and causing an injury. Then working with the ropes. These are called seamanship activities. Now you have to handle ropes, you have to tie the ship or the submarines alongside. So there's a lot of tension in these ropes. Increased tension in the ropes causes these ropes to break, they snap off, hit the eye, causing severe ocular trauma. Then moving from one ship to another ship, which is called a procedure called jack stay with the ropes, again, increased incidence of trauma. Now, I would be talking about various case scenarios specific to the ship. Now, this individual had an electric burn trauma with 20% of the body surface area was burned. He had actually a scar from the frontal to the occipital area. There was a live tension wire which fell on his head while he was working in the engine room. Now, he was evacuated to the tertiary care naval hospital, and ocular examination revealed that he had a traumatic electrical cataract of the right eye. Now, on examination, the lid, adnexa, conjunctiva, cornea, AC, the pupils had no abnormality, but there was only electrical cataract, which is the typical anterior subcapsular cataract, and it involved visual acuity. Now, this was a very rare case where only the lens was involved and rest of the structures were not involved. So he was taken up for a cataract surgery, phaco with IOL, and he had a good visual recovery. A second scenario, a second case where this person was working on the flight deck. He was hit by a sharp object in his left eye. Examination revealed a penetrating corneal injury with a nail which had just flown and hit his eye. He was managed conservatively, that is, evacuated with an eye shield. The nail was removed, the cornea was sutured, and a cataract surgery was done. And an IOL implant was put after a month. Then a third case scenario, where a serving sailor was securing the ropes. He sustained a blunt trauma to the right eye due to snapping of the ropes. Ocular examination revealed finger counting close to face. Again evacuated to a tertiary care hospital. He had hyphema, traumatic mydriasis, commotio retinae. A gonioscopy was done after a week. He had angle recession in the right eye. Now, he had traumatic hyphema. There was an angle recession. He was diagnosed as in case of angle recession glaucoma. He's been on anti-glaucoma medication, though the field examination reveals minimal field changes. Then there was another case, a battery blast injury, which is very common when you're working in the engine room. And this battery contains sulfuric acid. So this was a sulfuric acid injury. There was limbal ischemia, corneal haze, melting of the sclera. The sailor was managed with steroids and antibiotics on a long term, and then he's become all right. He has good visual recovery. Now, in a ship, initially when you have these type of injuries, you are initially taken to the small casualty room, which is called the sick bay in the ship, and there you are stabilized. And once you are stabilized there, you are taken to the helideck where there's a helicopter, and from there you are evacuated, if the ship is mid-sea, to the tertiary care center where he is treated born. Now coming to the ocular trauma, now I'll talk about ocular trauma. It is as per the Betz classification, where eye injuries are divided into a closed globe and open globe. Closed globe is contusions, lamellar lacerations, and an open globe, it can be a penetrating, perforating, or globe rupture. The ocular trauma scoring is based on the raw points, and the raw points are as per the visual acuity due to trauma or the injuries, that is a perforating injury, retinal detachment, APD, endophthalmitis. On the basis of this ocular trauma scoring with these raw points, we are able to give the visual acuity outcomes. Now, management of traumatic cataract. I'll be talking about traumatic cataract. So, traumatic cataracts occur secondary to blunt or penetrating ocular trauma. Penetrating trauma causes rupture of the anterior capsule with cortical changes that may be focal if small, or lead to total cortical opacification. In case of a blunt trauma where there is no ocular perforation, it is a rosette or a stellate shaped posterior axial opacities that may be stable or progressive. Blunt trauma with no capsular defect, as I've already told, is like a normal cataract where there are posterior stellate shaped opacities. In case of a penetrating trauma with an anterior capsular defect, it causes rupture of the anterior capsule. The cortex gets hydrated. The cortex could be flocculent and it comes into the anterior chamber, causing an endothelial touch, or it might be, as in this case, it is confined only to the capsular bag. The capsular trauma could be anterior or posterior capsular rupture. In this case, there could be a nuclear drop. Now, coming to the management of a traumatic cataract. Now, timing of a cataract surgery. Timing of the cataract surgery depends if the trauma is a blunt trauma or it's a penetrating injury. In case of a blunt trauma, one can go in for a cataract surgery at a later date. But in case of penetrating trauma, if the anterior capsule is ruptured, it could lead to a phacomorphic glaucoma. There could be a lens particle glaucoma. In case, as I've already shown in the previous picture, if there is a flocculent cortex, it could lead to an endothelial touch. So we have to operate immediately. Then there could be a globe perforation. There could be a corneal laceration. So we have to take the patient immediately. Modification in the steps. In modification, we have to go in for a controlled capsular access so that we don't put more strain on the zonules. Then in case there is a zonal adhescence, we have to go in for a CTR. Whether we have to put an intraocular lens at the same setting or not, again depends on the state of capsular bag. Intraoperative problems that we have commonly is there could be a vitreous prolapse, we have to go in for an anterior vitrectomy, there could be hyphema, and again an intraocular lens, whether we have to put the intraocular lens or not. And then post-op rehabilitation. In post-op rehabilitation, the patient is left aphakic, and the lens has to be put at a later date. The patient might have angle recession glaucoma, there might be astigmatism because of a corneal laceration. He has a high astigmatism. Now, again, management traumatic cataract, which I have said, in case of blunt trauma, we treat it like a normal cataract. Now, in case of a corneal perforation or a traumatic cataract, primary repair, if there is a primary repair, is a priority. That is, globe integrity is of paramount importance. If we cannot go in for a cataract surgery because of corneal edema or there is a uveitis and IOL power cannot be calculated, just close the eye, suture the cornea, and then we can take it up at a later date, cataract surgery. Primary repair with cataract surgery is done if there is a capsular breach, there is cortical matter in the AC, endothelial touch. We need to go in for a cortical wash and leave the capsular frills as they are. Certain take-home points about the traumatic cataract surgery: always stain the anterior capsule. Use retroillumination, look for the capsular tear, use forceps. Zonal integrity, if the zonules are weak and there is zonal adhescence 30 to 90 degrees, use CTR. If it is more than 90 degrees, go in for Sionese rings. About cataract surgeries, if the bag is unstable and it is weak, use iris or capsular hooks. In case of soft cataracts, use irrigation aspiration. And if case there is a senile component, we can go in for a phacoemulsification or SICS. Always use low surgical parameters. Intraocular implantation, if it's in the bag, prefer IOL, acrylic IOL is preferred. In the sulcus, if we have to put, then a multi-piece or a PMMA. If there is absence of capsular support, then an SFIOL, which can be a glued or suture fixated. There is a surgery, a small clip where there was a perforating. It's not working. The video is not playing. Okay. In case of 60% of the, talking about angle recession, 60% of the eyes with non-penetrating or concussive trauma will develop angle recession. It is strongly associated with traumatic hyphema. If there is more than 180 degree of angle recession, they are at high risk of developing glaucoma. Treatment is medical, anti-glaucoma drugs, or surgical. If you go in for a trab, there is high risk of failure. Causes of injury, as I've always told in the ships, is because of slipping, tripping, falling, equipment-related inadequate training, fire and electrical injuries, welding and chipping activities. We need to take precautions in the form of eye goggles. The first aid and evacuation, that is, follow the ABC for eye injuries. Always check the visual acuity of the person once he has an ocular injury. Best examination of both the eyes. The contiguous structures of the eye should also be seen, not only the part that is injured. Do not instill, in case we are suspecting there's an open globe injury, do not instill any drugs or drops. Put an eye shield. Do not put any pressure on the eye. Put an eye shield and evacuate the patient. Management at the tertiary care center is whether it's surgery or admission and monitoring. And patients, once they are admitted to a tertiary care center, are given a period of convalescence and they are monitored in a sheltered appointment. Thank you.